my name is Ellingson. For those of you that don't know me, I'm one of the third-year EM residents doing the trauma conference today. First off, just want to give a shout out to the Wild. Colin's got the Wild shirt on. They came up with a big victory last night, so moving on to the second round of the playoffs. Although I don't have any specific conflicts, someone did inform me that they would buy me breakfast after the talk this morning, so I don't know if that counts. But so we got a case here. We have a TTA paged overhead. It's 5 minutes out. Charge nurse comes up to you. He's like, it's a 30-something-year-old in MVC. You get your whole team assembled. You're all waiting anxiously. 5 minutes is turning into 15 minutes, and then this rolls in the door. And I think at this point there's probably a lot of mixed emotions. If you happen to have, are fortunate enough or happen to have done a partial OB residency, you might be kind of excited. Although the rest of us might have a little more kind of mixed emotions. Some of us might be kind of scared or maybe even crying a little bit. Or maybe just want to run and hide. So all of those reasons, I think this is a good topic to cover. Because I think it is something that is potentially anxiety provoking. We don't see a lot of at least the severe trauma or severe pregnant trauma. So we'll kind of go through those things listed. So epidemiology wise, trauma in pregnancy actually is common. It's about 6 to 7% of all pregnancies. But in terms of the bad ones that require admission, it's only about 0.3%. Most commonly is due to motor vehicle crashes and falls. It's always important to remember that domestic violence is another possibility. It's probably significantly underreported. This is the leading cause of non-obstetric maternal death with a 7% maternal mortality. And fetal mortality is quite high. With major trauma, it's 60%, and if there's any maternal shock, 80%. But the scary part is even with minimal trauma or even no abdominal trauma, you can have issues with fetal loss up to 5% of the time. And can you guys hear me all right? And if anyone has questions, just feel free to shout them out. This is informal. So pregnancy is fairly complicated. It changes the female body pretty much every way possible. Anatomy is different. Pretty much every physiologic system is different. So we'll go through just some of the basic physiology quick because I think it's important to get just a basic understanding when you're working up pregnant patients for trauma or medical reasons. Obviously the anatomy is different. When the fetus grows, all of the organs are displaced. So the fetus often gets the brunt of the injury with abdominal trauma. From a hematologic standpoint, the blood volume increases by up to 50% throughout pregnancy. It's more of a relative anemia because it's more plasma than it is actual RBC volume. And why this matters is you can have up to a third of your blood loss before you actually see any hemodynamic changes. Part of this is protective during pregnancy, vaginal delivery, C-sections. You're going to have blood loss, but usually there's no maternal effects from that. But it's just important to kind of be cognizant that if you have a hypotensive person, they're probably more depleted than they actually are. There's a leukocytosis during pregnancy, not specifically affecting trauma, but from a cardiac standpoint, blood pressure does decrease throughout pregnancy by up to 15%, but by the time you're at full term, usually it normalizes. They do tend to be kind of borderline tachycardic, and the cardiac output increases by 50%. A quarter of this goes to the placenta, and so during any hemodynamic compromise, if there's any real tenuous situations, you're shifting your blood towards your brain, your heart, the placenta and the uterus are compromised, so there actually is little reserve for the fetus. There's this kind of entity known as supine hypotension syndrome. This is when it happens after about 20 weeks of pregnancy, when the fetus is sufficient size to compress the aorta and the IVC. Ends up decreasing venous return and ultimately cardiac output. pulmonary standpoint, as the baby grows, your diaphragm's higher, your total lung volumes are substantially smaller, and your functional residual capacity is smaller. And this is important because that's kind of what that is kind of protective, gives us kind of safe apnea time, so they're more compromised, they're at risk for desaturating and becoming hypoxic quickly. Because they also have a fetus growing inside of them, their oxygen content is higher, all their metabolic tissues are revved up, they're hypermetabolic. So all of these things make the pregnant patient more prone to desaturation. Also, the minute ventilation goes up, so they do have more of a respiratory alkalemia during pregnancy. GI-wise, they do have a higher aspiration risk for several reasons. The delayed decreased gastric emptying, decreased motility, and the effects of progesterone decrease the esophageal tone. And also, importantly, they have a very insensitive abdominal wall. This is something that I had forgotten. I probably shouldn't have mentioned that, but it's important because they can have a really benign abdominal exam and actually have significant abdominal injuries, so they can have hemoperitoneum or some other abdominal catastrophe, and it would really not show up on the abdominal exam. And it's partly because of the stretched musculature and the peritoneum, so it's very unreliable. From a GE standpoint, the bladder is at increased risk of injury during later in pregnancy because it comes out of the pelvis. And then it's just important to remember that obviously the pubic bones change, so they're going to have a widened pubic symphysis at baseline. That being said, they do have increased risk of orthopedic injuries because they have increased ligamentous laxity. So now the patient comes into the trauma bay. You're going to do your primary survey. And unfortunately, there's not a lot different between the primary survey of a pregnant patient and any other trauma patient. You're going to do your ABCs. The saying is that what's bad for the mother is bad for the baby. The most common cause of fetal demise is maternal demise. So, but that being said, if the patient comes in and they have the big exclamation point on their abdomen and they're pregnant, then you can at least be cognizant that they are more susceptible to hypoxia and hypotension, and try to get on that early, and then also potentially getting your consultants involved early, getting OB involved. So we're just going to go through some of the big differences in the primary survey quick. So from an airway standpoint, like I said, they have increased risk of aspiration. The other thing is they have a more difficult airway. They have all these physiologic changes. They have edema and water retention in their larynx, in their tissues. They're more hyperemic, prone to bleed just with even minimal trauma like nasal trumpet. Those sorts of things can precipitate some bleeding. They also have more just adipose tissue around their face, neck, chest. All of these things create not an ideal situation from an airway standpoint. So in the really bad trauma that does need to be intubated, this is the one patient population that you really want to anticipate. I know we always stress every airway you should prepare ahead of time, anticipate for the worst. I think sometimes we get a little complacent because we don't have a lot of failed airways. I don't mean offense by this, but it is more treat this like the obese airway because they have the same physiologic changes, anatomic changes, and even the anesthesia literature shows a higher complication rate with pregnant patients in terms of getting intubated. So things you can do to kind of help prevent this, and we'll just touch on it briefly, but it's pre-oxygenating and apneic oxygenation, which we should be doing on pretty much every patient in the ED right now. There's a lot of good literature that it improves your apnea time. Other things that help, you can sit the patient upright. This helps get a lot of the body kind of adipose and weight off the lungs, decreases atelectasis, decreases VQ mismatch. So potentially helping oxygenation. In the trauma situation, this can be a little difficult, but you can put them in reverse Trendelenburg, especially if it's like a tenuous situation or oxygen sets are kind of borderline. I would definitely consider that. And then having even smaller ET tubes than we typically would, because their airway actually is smaller, so maybe even having another half size down from what we normally would do, and then backups obviously readily available. From an oxygenation standpoint, like I said, they're prone to apnea, but the fetus is very prone to just even early changes of hypoxia that may not be evident. So all these patients should get supplemental oxygen right off the bat. They generally do anyways, but it's important in this subset of patients until you can kind of reassure things that there's no fetal distress. And in terms of the goal kind of PaO2, they say over 100. We're not ever checking ABGs in the ER, well, hardly ever, I should say. But once you get to about a PaO2 of 60, your oxygen sats are about 90%, and that's kind of right on the steep curve of the oxyhemoglobin dissociation curve. So that's where they can really precipitously drop. And that's when the fetus will get the diving reflex, where they're shunting blood towards their brain and heart, as opposed to the other organs. So you should shoot for sats of greater than 95%. Ventilation-wise, they are going to be harder to bag. You need to use a bag valve mask. They do a few good things going. They don't have, facial hair, probably. They probably don't have dentures. So all those things are helpful, but they have decreased chest wall compliance, they have increased abdominal pressure. All of those things make it more difficult. And then because of their increased ventilation, their PCO2 is going to be upper 20s, low 30s at baseline. So a normal PCO2 for us is not normal for the pregnant patient. Now, they may tolerate it just fine, but again, you also have to consider what the fetus is seeing, and if it gets to that point, they may have some hypoperfusion from nasal constriction. If there's a pneumo or hemo, and you have to put a chest tube in, you should go at least 1 or 2 rib spaces higher, so you're in the 3rd or 4th intercostal space. Because the diaphragm's higher, you really don't want to put an abdominal chest tube in. Vascular access, if possible, you should go upper extremities. Because of the IVC, there's some compression that potentially hinder your resuscitation. So, IV access, upper extremities. If you can't do that, an IO in the humeral head is just as good as the tibia. I know we generally just do tibias, but that would be a good second option. So the subset of patients here that say this pregnant trauma patient's hypotensive, this gets a little complicated because there's a lot of different reasons it could be hypotensive. It could be just as if their normal physiology, is it supine hypotension syndrome, or is it related to trauma? Now you should always assume it's due to trauma if it's a TTA, but it's kind of tough juggling all those things. So if the patient is already hypotensive, you should be scared because you're probably behind the 8 ball, because they can lose 2 liters of blood before they even get any hemodynamic changes. So even if they have normal blood pressure, just getting empiric IV fluids, 1 or 2 liters isn't going to hurt the mom or the baby. Because again, what the maternal blood pressure is does not necessarily reflect what the fetal blood pressure is. And then in terms of this supine hypotension syndrome, again, like I said, it's over 20 weeks that you worry about it. Less than 10% of the patients will actually get kind of shock symptoms from this entity, but you should treat all of these patients like they have it, because it'll help augment their cardiac output by up to 30% higher. And you can do just a couple different simple maneuvers. You can either put them in the left lateral decubitus position, so if they're trauma and they're on a backboard, just tilt the backboard up 15 to 30 degrees. Otherwise, you can just manually displace the uterus to the left with your hands. So this is kind of this one here. They're just someone can literally just pull the uterus off the IVC. And so from a secondary survey, you're going to work up maternal injuries as you always would. Not a lot of difference there, but this is when you really focus on the fetus as well. Asking the mom if she knows how far along she is can be helpful. If she's had any prenatal care. using a last menstrual period is pretty inaccurate at a guesstimate, but you can check fundal height or use ultrasound, which are good options. This is when you also want to look for fetal heart tones, doing the cardiac monitoring, and then getting a good abdominal exam if there's any uterine contractions. I don't know if I would be able to feel that, but and then the vaginal exam, I think this is something that I probably wouldn't do, at least in the severe trauma patient early on. If there's vaginal bleeding, you definitely do not want to do a pelvic exam in the second or third trimester because you could precipitate hemorrhage through the placenta previa. So unless you have OB there or like an ultrasound that confirms this is not the case, then you could. You can always do an external genitalia exam just looking for lacerations, open fractures, those sorts of things. But there's really not a great role for doing like an actual full pelvic exam on the trauma patient. In terms of the fundal height, the only real measurement that I remember is that the umbilicus is 20 weeks. It's 1 centimeter is each week, kind of above and below that. That's kind of the threshold for liability. 24 weeks, but with air usually sitting about at the umbilicus. So yeah, in terms of the trauma workup, you're going to do the same studies that you would do if she wasn't pregnant, but now you also have to focus on what you want to do for the fetus. And again, just remembering that there can be really no or minimal trauma to the abdomen, and you can still get fetal compromise. So that's always important to be cognizant of. And so we'll kind of go through some of the things we're worried about here. So we'll go into some of these more in depth, but you have fetal and maternal hemorrhage, abruption, premature labor, uterine rupture. It's very rare. It's primarily seen in like multips, people that have had C-sections before, and it's usually fatal. Direct fetal injury, usually it can be a little more obvious because it's generally either a gunshot or a stab wound to the uterus. And then amniotic fluid embolism, we're not going to really get into, but it's pretty rare and it's a high mortality. So fetal maternal hemorrhage, and this is something that you're always worried about, even in just vaginal bleeding, miscarriage patients too. And this is when you have an Rh negative pregnant patient, you worry that they'll become allo-immunized. So if they have an Rh positive fetus and they have kind of transplacental hemorrhage, they can develop antibodies that don't affect this pregnancy, but future pregnancies, they can develop antibodies and cause problems in the subsequent pregnancies if the subsequent pregnancies are Rh positive. So it can cause things related to hemolysis, so anemia, kernicterus, neurologic damage, hydrops, fetalis is kind of the classic one where you get essentially high open heart failure. And it's actually pretty common. Up to 40% of traumas will actually have some hemorrhage, and there's not really any great way to predict which ones don't have that. Fortunately, there's a good treatment that prevents this called ROGAM, and this is something they give just in normal pregnancy. So they've shown that even in just normal pregnancy patients that don't get ROGAM, they'll see this in up to 17% of patients. So definitely common. But it only takes 0.0 cc's of actual hemorrhage to potentially become allo-immunized. And so the dose of ROGAM is, the full dose is 300 mics. That's generally what we give. Some people will do 50 mics at less than 12 weeks. But that covers up to 30 cc's of hemorrhage. And you do have 72 hours to give it. I think generally you should give it early in the workup so it's not forgotten, but say the person's really critically ill, and you really just don't have time to do it initially, just make sure you kind of close the loop and pass on to the next team that, hey, we need to remember to get this person ROGAM. But you do have up to 72 hours for that. So in terms of the Kleinow or Becky test, so this is essentially like a quantitative test for assessing how much fetal blood is in the maternal blood. Generally recommended at 20 weeks and on to obtain this test. At less than 16 weeks of pregnancy, there's not even 30 cc's of blood, so the dose of ROGAM, you'd have to completely hemorrhage all your blood before you'd dose of ROGAM. So I think that's part of the reason why it's at 20 weeks. But some sources say to get this regardless of the RH status, so RH positive or negative. I think the role with an RH positive patient is probably limited because there's really no predictive value in this test. If it's positive in an RH positive patient, it doesn't necessarily predict complications. There may be a little longer monitoring that you do, but it probably doesn't change management. But for the RH negative patient, if it's positive, the inpatient team, the OB team, can use it to see if they need to redose ROGAM. So if there's more than 30 cc's of hemorrhage, then they would potentially have to redose. In terms of placental abruption, so this is pretty common, seeing 5% of just minor trauma and up to 50% of major trauma. However, given that there's a lot more minor trauma, about 50% of actual fetal losses are just minor trauma. The classic triad they teach in med school is vaginal bleeding, uterine irritability, abdominal pain. It's not common, less than 50% of the time. And the best way to really diagnose this are kind of a combination of physical exam, ultrasound, and fetal monitoring. So ultrasound is a great test. If it's positive, it's very specific. However, it's not sensitive. It's less than 50% sensitive. Versus monitoring, it's good at picking up fetal distress, but it's not good at deciphering why there's fetal distress, so it doesn't rule in a placental abruption. And there's this one study, I think it was in Norway, the mortality is quite high in patients that had abruption, up to 75% mortality. And they did like a case fatality. They looked back at kind of case fatality rates, and it looked like there's a 69% were prevented by C-section. It's definitely important to pick up. And the reason why you don't see vaginal bleeding with all these is because you can have concealed hemorrhages versus the one on the left where you're getting bleeding. So the monitoring, this is for one, assessing fetal heart tones, and then also just the uterine contractions, irritability. You do this once a patient's 20 weeks or greater, because this is when they're viable. And things they look for, particularly the OB nurses and the OB team, they'll look for fetal distress, looking at kind of heart rate pattern, if it's bradycardic, tachycardic, lack of variability. And the main benefit for this is more just reassuring that there's nothing wrong. It doesn't really change outcomes. If it's abnormal, it actually could be one of the first things you see if there's kind of impending maternal shock. But in terms of preventing fetal deaths, it doesn't do a great job at that. If there's no fetal heart tones, absent fetal heart tones, then this one kind of review that had 441 trauma patients, there were no survivors. So they recommend do not attempt any resuscitation, or fetal resuscitation in that, if that's the case. However, if it's normal, it is good. It's 100% negative predictive value. And they essentially look at if there's a certain amount of contractions per hour, no uterine pain, so no abdominal pain, no vaginal bleeding, less than 6 contractions an hour. They'll monitor for 4 hours. If that's fine, usually they can go. Now the other question always is this, are they in labor? They have premature contractions. It's common to have premature contractions with trauma, just due to irritability. Up to a third will have this, but it's rarely actually ends in preterm labor. Now, if you're curious where this vaginal fluid is coming from, you can test it a few different ways. I hope I'm never in a place where I have to test vaginal fluid, because I honestly hope there's like an OB nurse or an FD or OB around. But, so you can either do the nitrazine paper or ferning. Interestingly, the nitrazine paper, it turns positive if it's alkaline fluid. It also turns positive if you have bacterial vaginosis, if you have urine, or potentially get urine or blood. So there's a lot of things that can be positive. So the specificity is not great. And ferning is a good test. You just have to dry some amniotic fluid on the slide, and you essentially see a fern pattern. So in terms of fluid workup, we do ultrasounds on all trauma patients. So the EFAST, it's quick, it's easy, there's no radiation exposure. It's a specific test. It's really sensitive and specific for pneumothorax. The sensitivity is not as great for intra-abdominal hemorrhage, probably less so than the non-pregnant patient. The highest sensitivity is probably in the first trimester, but it's probably, as we all know, it's most useful as a screening tool. If it's positive, that's helpful. If it's negative, you kind of got to use the whole clinical picture and help guide management. You can also use it, one, to diagnose pregnancy, checking fetal heart tones. It's a great way to estimate gestational age, particularly if it's in the first trimester. As you get closer towards term, it's a lot more inaccurate, off by several weeks. And then, always a fun topic, at least in the emergency department, is discussing radiology images in the pregnant patient. I don't know if I can think of another topic that I dislike as much, but so there's not a lot of great data, which is part of the problem, but a lot of this is extrapolated from atomic bomb blast victims. And the big thing is to think about are like how far along, what's the gestational age, what body site, are you imaging their hand versus their abdomen? That's obviously different, and then the type of imaging, CAT scan, X-ray. And the big thing to worry about is the teratogenic effects and cancer risk. And so, the main time period where you're worried about teratogenic effects is 8 to 15 weeks. This is the period of organogenesis. This is when you see intrauterine growth restriction, mental retardation, CNS effects, microcephaly. And so there's guidelines from ACOG, which is the OB guidelines, and ACR, our radiology guidelines, and both of which say that less than 5 rads or 50 milligrade, there's really no risk to the fetus. And even up to 100 milligrade or 10 rads, there's probably no risk either. ACR does say that there's no one test that you can do that is harmful to the fetus. So, if you're in worst case scenario, trauma pan scan, you're still not likely exceeding the threshold of 5 rads. The problem is on the badly injured patient that's getting repeat imaging. That's where you kind of get into this issue of kind of getting above the threshold. In terms of the cancer risk, this is even less clearly delineated. It's still felt that less than 5 rads, there's probably no risk. And the highest risk is in the first trimester at increasing cancer risk, particularly with childhood cancers. One of the other kind of radiology guidelines that mentioned that, and they said may, I don't know how much evidence is there, but it said may increase the risk of a combined effect by 1% if they're over 10 rads. So when you look at these are charts of, these are kind of primarily x-rays up here, CAT scans, and this is the fetal dose that they're actually seeing. And if you look like a head CT, they have 0 milligrams. The big ones are, like this was interesting, a CTPE, 0.2 milligrams. But a CT chest, abdomen, pelvis, like angio, is 34. Obviously the big exposures when you're to the fetus is when you're radiating the pelvis. The other question is, how does contrast affect pregnancy? We know that contrast and iodine does cross the placenta, so there's obviously some theoretical risk to the thyroid. However, there's not really any evidence to support this risk. But that being said, they recommend using caution when using contrast. Use it only if needed. The other study that we talk about a lot in pregnant patients is an MRI. It's great because there's no radiation. It's pretty limited in the trauma setting because of obviously the length of time compared to a CAT scan. And the contrast risk, again, not really known. Gadolinium with animal studies and very high doses and repeat doses, it has been shown to increase teratogenic effects, but there's no harmful effects. There's been no human studies, but there hasn't been any case reports of harmful effects known to be due to MRI contrast. So, in terms of kind of summarizing radiologic issues, so I was going by like ALERA principles, which is as low as reasonably achievable. And getting your radiology colleagues involved, because they can help kind of combine tests so you're less redundant, shield the pelvis to help minimize radiation, and they can even like widen out the cuts with the imaging so you get less radiation exposure. It does change the sensitivity a little bit, but potentially would still be acceptable. But the big take-home point is that if you're going to order a certain test on a non-pregnant patient, then you should order the test on a pregnant patient. There really isn't any circumstance where you should not pursue the test. And so on EdNet, we do have guidelines for trauma and pregnancy for non-TTA and TTA criteria. I think kind of the main one that we've been talking about is greater than 20 weeks. So you have, they kind of break it down in an algorithm. So in terms of the stable mother, stable fetus, then you just kind of admit for monitoring generally to OB. If it's a stable mom but an unstable fetus, then generally the fetus should get a C-section if it's of viable age, which here is 23 weeks. And then if it's an unstable mom, depending on where the injuries are, if it's an abdominal, you have to go to the OR for an abdominal injury, then generally OB and trauma go together. But if it's something unrelated, then the fetus should still have monitoring, but OB doesn't necessarily have to be involved. So this very rare arresting pregnant patient we'll touch on quick. So in terms of what to do, you pretty much do the same thing that you do for the non-pregnant patient. The AHA guidelines are the same in terms of when to defibrillate, the dose to defibrillate, rate of compressions. Even the medications are pretty much the same. There's maybe some risk about amiodarone, but I think that's very minimal. If you feel like that you need to give amiodarone, the risk-benefit ratio probably favors giving it. But so the main differences are whenever you have an arresting patient, you want to displace the uterus, and you can do the tilt. But they've been shown that there's maybe a little less effective chest compression, so just having someone displace the uterus manually may be more optimal. And then you may also have to do compressions higher up on the chest, particularly farther along in pregnancy, because the uterus obviously displaces the heart and everything more cephalad.
The part about the tilt, were any of those studies done with the Lucas?
I don't know that.
Maybe negating that
Yeah,
has
that's
to go to
true.
mechanical.
Yeah. Yeah, that's right. So now we'll talk just briefly about perimortem C-section. Very rare. It's more like kind of case reports in the literature, but there's definitely well-established guidelines for when to do this. If it's less than 20 weeks, there's really no benefit to ever doing this. Between 20 to 23 weeks, the benefit is for maternal benefit. So getting the baby out can potentially help hemodynamics because of supine hypotension syndrome. After that, at about 24 weeks and on, there's potentially benefit for both the fetus and the mom. And so there's this 5-minute rule. Generally, this is when hypoxia starts to set in at about 5 minutes. So after about 4 minutes of CPR, or I should say after 4 minutes of CPR, you need to make a decision. If you're going to do this, you need to commit and have the baby out by 5 minutes. And I've looked back, and kind of a lot of these will happen after 5 minutes. It's because there's provider hesitation, which rightfully so. This is kind of like a moribund procedure. That being said, the mom and the baby are already dead, so it's a potentially life-saving thing. So it's definitely something to consider. especially at a facility like this where you can get OB trauma. Everyone's down there very quickly. And so this review had 61 patients over 85 years. Just kind of shows how rare this is. But there was 70% fetal survival if it was done within 5 minutes, all of which were neurologically intact. After this, there was a lot more neurologic sequelae, and really after 25 minutes, there hasn't been any reported survivors, fetal survivors or maternal survivors. So the big thing is don't delay doing this if you're going to do it. Like I said, there's also some maternal benefit. There's been reports that this actually improves maternal mortality. So in terms of how to actually do it, one, you want to make sure that the pregnancy is viable, or you think it is, so 20 weeks or greater. Try to get as many helpers as you can, and if possible, maybe even dividing up into teams. So you have like a team for the mom, someone's actually doing the procedure, and then a team for the baby. And then it's important to remember to do CPR throughout the whole time that this is ongoing. And you really only need a scissors and a scalpel. You pretty much are going to make an incision from the xiphoid all the way to the pubic symphysis, and then start making an incision through the fundus, trying not to hit the baby, and then using the scissors the rest of the way to extend it, so you're not cutting the fetus, and then delivering the baby placenta very promptly. And you don't have to close it right away. You can pack it and deal with that later as you're kind of dealing with the rest of the resuscitation. And this was an interesting article I saw in the Star Tribune a couple weeks ago. This was out in Maine. There was this guy who was driving behind someone. He saw a porcupine get hit by a car, and he had heard this like fairy tale from his grandpa or someone that there's these valuable mineral deposits that's used in Chinese medicine that forms in the stomachs. So he went over and cut this thing open, and he found a baby. The baby wasn't breathing, so he started massaging it. Cut the umbilical cord, and got it back to life. And so you never know when you may have to do
Not the mom.
Yeah, she did. All right. Any questions? Yeah.
Have these perimortem C-sections ever happened, like for staff here? Have they happened in the current year before?
Oh, yes.
We do one every couple of years, meaning we as like somebody in our group.
Yeah.
There's
And
one.
you like call OB right away?
Oh, and OB will come with the scalpel running. If you call an OB stat for a trauma and you truly have a perimortem C-section, they will have the baby out in 3 minutes. And I've done one that wasn't quite perimortem, but yeah, and they are good and they are fast. And if they are anywhere nearby, it's so much better to have them doing it than me. Because my brain's not in a good place. I now have a dead mom and a dead baby in front of me, inside each other, and I want someone else doing it if I can. But yeah, they come fast.
But technically, the procedure is not rocket science.
Right.
Yeah.
It's good baby.
Yeah. Couple of slashes.
What?
I think
Couple
the
of
situation would
slashes.
be tricky is if you're in a smaller community hospital where you don't have, I guess OB might be in-house, but you're not going to have proper trauma surgeries that are.
When I was a resident, one of my fellow residents did it in a home off a helicopter. So it can't be
Wow,
wrong.
that's-
Needless to say, mother didn't make it, and baby had neurologic compromise, because by the time a helicopter gets there, it's more than 5 minutes.
We've done it in the SI.
In the SI?
Yeah. The splenic artery aneurysm.
Oh.
But I did it in the SI. So occasionally
Yeah.
we've had to.
Hey, Eric.
Yeah.
So first of all, this was great. Thanks for the review. The comment I wanted to make was you had the slide up about the placental abruption. And the top line, I just wanted to highlight, especially for the emergency medicine residents, that this is nice to hear about the severe trauma workup and how you're gonna manage things for these pregnant TTA type patients,
Yeah.
but the most common thing you're gonna see is a low mechanism of trauma in somebody that's pregnant.
Yep.
And first of all, to just remember that that is something that you have to pay attention to and think about how many weeks they are and communicate with labor and delivery to do the fetal monitoring and everything is really important. The second part of it is depending on where you go to work, they're gonna have a different cutoff for the weeks. So you might hear 20 weeks, you might go somewhere, you might call it 23 weeks, and they might say, no, here we monitor at 24 weeks or whatever it is. So it might be different based on the OB group that you're calling. And the last thing to remember is some of the stories they'll tell you about what happened, it could turn out to be that it's an abuse type situation. So they always say that pregnant mothers that come in with this low mechanism trauma, it's really important to cover that just because for a lot of them the stories they're giving are just cover-ups for what's happening at home. So as we should always be doing anyway in the ED, checking for domestic abuse, it's just something that's especially important to ask for these pregnant patients because what you're doing that time might not be as important as just making sure they're safe to go wherever they're going to get to. So that line that he had is just something to pay attention to with, even though it's a minor trauma, they just fell down a stair or whatever it is, it doesn't sound bad, it's something you just have to pay attention to.
So one of the narratives that are down there, out there because of that is actually a pregnancy will decrease your center of gravity. So, and that, just like little kids that are on the ski slopes never fall down and everything like that because their center of gravity is low, is that unless there's sort of a trip and all that, the chances of falling actually may decrease when you're pregnant. It's a narrative out there. I'd like to know if other people have heard that or if that's been challenged because the whole, I fell down. I can imagine there's falls, but at least one of the OBs I work with said, just be careful of this whole I fell down while I was pregnant.
Yeah.
I can see myself tripping over something because the ground is right further.
Yeah, I did.
Less than once.
I was running to a TTA and I went down. So. Serious. I normally don't run when I fall. You can't fall very well once you're in the ground. That's just it. You can't catch yourself.
Yeah.
So.
No, the woman, the residents,